Candidiasis. Infections caused by fungi are called mycosis, and the study of fungal infections is mycology. Most fungi are associated with human diseases are saprophytic members of soil. Others exist either as commensals in the alimentary tract or as harmless residents of the skin and the mucosa, and only infrequently assume the role of a pathogen. The main morphology of fungi can be as yeast-like cells, as pseudohyphae or hyphae, blastospores, and chlamydospores. Species of the Candida, Mucor, and Rhizopus are the common opportunistic pathogens which are frequently implicated in the etiology of fungal infections in patients who are either immunocompromised or debilitated. The most common of this is Candidiasis. The causative organism for Candida oral candidiasis is Candida albicans, although others of the Candida genus like Candida tropicalis, Candida parapsilosis, Guillermondi are a few of the others which are also implicated. The older terminology for this is moniliasis, which comes from the term Monilia albicans. The organism is present as a commensal in the digestive and in the vaginal tracts, and it exists mainly as two main forms. So it's also called as a dimorphic fungus, and the hyphal form is relevant to pathogenicity. The biology of Candida albicans is that it switches from a commensal to a pathogen depending on the immune status of the host, on the immune factors related to the host, and to the organism's virulence. This is a thin-walled dimorphic fungus, which can also present as a unicellular yeast form, which is harmless, and the filamentous or pseudohyphal form, which is pathogenic. The third form in which it exists is the chlamydospore form. The two main cell wall polymers for Candida albicans are the glucan and mannan, and these have a role in the pathogenicity of the infection. Predisposing factors are very important for causing Candida infection. These can be broadly grouped under two categories, the local factors and the systemic factors. The local factors are related to topical use of steroids, xerostomia, and poor oral hygiene. Systemic antibiotic therapy is one of the main factors which are responsible for causing Candida. Other factors include infancy, old age. Important is endocrine disturbances like diabetes mellitus, which make the person predisposed to develop Candida infections. Other endocrine abnormalities include hypothyroidism, physiological state of pregnancy, and the use of systemic steroids. Advanced malignancy, cancer, chemotherapy, or radiotherapy are also implicated in development of Candida infection. Additionally, nutritional deficiency can cause Candida infection. Oral candidiasis is not recognized as an indicator disease for HIV infection and AIDS. So immunosuppression caused by HIV is an important predisposing factor for oral candidiasis. The pathogenesis of candidiasis evolves through certain stages. The stage of colonization, where the candidal hyphae adhere to the surface of the epithelial cells through virulence factors called adhesins and hydrolytic enzymes. The second stage of the pathogenesis is that it causes a superficial infection of the surface epithelial cells. This is by epithelial penetration with formation of hyphae. And here also hyphal formation and hydrolytic enzymes are responsible for the pathogenesis. The third stage is a deep-seated infection where there is more deeper tissue penetration, vascular invasion, and immune escape or evasion. This stage is usually associated with more intense immunosuppression, and these are the virulence factors which are involved, namely the hydrolytic enzymes, the hyphae formation, and immunomodulation by the organism. The fourth stage of pathogenesis is disseminated infection, widespread infection, where there will be activation of infection of other host tissues. And at this stage, the host or the patient is usually severely immunocompromised. So normally what we see is just a superficial infection or a colonization, and 3 and 4 stages are usually associated with immune suppression. The classification of oral candidiasis goes as acute and chronic, while the classification given by Axel and Samranaike in 1991, which is what is widely followed, divides candidiasis into group 1 lesions and into group 2 lesions. Group 1 lesions are primary oral candidiasis, while group 2 are secondary oral candidiasis. The primary lesions are usually confined to the oral and perioral areas only, while group 2 lesion is a generalized candida infection, which is usually secondary to some other inherited immune defects. Group 1 lesions are further categorized into 4. First one is acute, which includes pseudomembranous and erythematous candidiasis. The second is chronic, which includes hyperplastic candidiasis, in addition to erythematous and pseudomembranous types. The third one is candida-associated lesions, which includes denture stomatitis, central papillary atrophy or median rhomboid glossitis, and angular cheilitis. The fourth in group 1 is keratinized primary lesions superinfected with candida, which includes all the white lesions, namely leukoplakia, lupus erythematosus, and lichen planus. Now, clinically, candidiasis can present with a very wide range of presentations, which include either as a white lesion or as a red lesion or as a red and white lesion. The most commonly recognized form of candidiasis is oral thrush, which is also called as pseudomembranous candidiasis. This is usually seen as creamy, soft, white, slightly elevated plaques which can be wiped off. The patient usually is asymptomatic. Sometimes they may give a complaint of a foul taste in the oral cavity. There are 2 forms for pseudomembranous candidiasis. The acute form, which is usually caused by antibiotic therapy, follows a course of broad spectrum antibiotic therapy, while the chronic form is usually seen with more severe immunosuppression, chronic immunosuppression, which may be an inherited disorder of immune system or it can be HIV. The pseudomembrane, this wipeable, creamy, thick plaque, is what is called as a candidal pseudomembrane, and this is composed of a tangled mass of fungal hyphae, desquamated cells, keratin, as well as leukocytes or WBCs. Now, this plaque, if it is wiped off, it will leave a red erythematous area in the mucosa. The second form of candidiasis is what appears red instead of white plaque. This appears as a red lesion, and there are about 6 forms which appear as red erythematous candidiasis. The first one is called acute atrophic candidiasis or antibiotic sore mouth. So as the name suggests, the cause of this form of candidiasis is usually antibiotic therapy. Broad spectrum antibiotic usage, indiscriminate usage can result in erythematous candidiasis. This presents as red atrophic areas with loss of filiform papillae, and this is usually symptomatic, and the patient complains of a scalded feeling in the oral cavity. Another type of erythematous candidiasis, which appears red, is seen on the dorsum of the tongue as an ovoid or a rhomboid area, which does not have any papillae. And this usually represents an area of chronic candidiasis on the mid-dorsum tongue. Previously, this was thought to be a form of developmental anomaly. However, it is now recognized as a form of candidiasis, which is also called as median rhomboid glossitis or central papillary atrophy of tongue. The other forms of erythematous candidiasis include chronic multifocal candidiasis. This is usually occurring from lesions on the tongue which touch the palate and cause lesions on the palate as well as on the buccal mucosa. So here in the third type, in chronic multifocal type of candidiasis, there will be lesions in multiple sites of the oral cavity due to contact. The fourth type is angular cheilitis. Angular cheilitis or perleche is seen at the corners of the mouth as radiating fissures usually caused by decrease in vertical dimension of occlusion, as a result of which there will be pooling of saliva and overgrowth of candida. Chelocandidiasis is a form of candidiasis which affects the perioral region surrounding the lips or the vermilion zone. The sixth and last type of erythematous candidiasis is called as chronic atrophic candidiasis or denture sore mouth or denture stomatitis. Here, there is an area of erythema seen beneath the area of the denture base of a maxillary denture. So beneath the area of maxillary denture, there will be an area of erythema which is caused by candida infection. And it appears as a diffuse inflammation of the denture-bearing area, characterized by different degrees of erythema, and it will be localized to the denture-bearing areas only, and only for a maxillary removable denture, because for a mandibular denture, saliva usually has a cleansing effect. Saliva's antifungal and antibacterial components usually have a protective effect. The next type of candidiasis after pseudomembranous and erythematous is the type called as chronic hyperplastic candidiasis. This is also called candidal leukoplakia. This is a white lesion which is non-scrapable. Unlike the pseudomembranous type, this cannot be scraped off, and it's seen usually in the commissures of the buccal mucosa, buccal commissural area. And the importance here is that this is associated with epithelial dysplasia in some cases, which means that there is a potential for malignant transformation. The id reaction is a hypersensitivity reaction to candidal antigen. It is seen as a rash on the skin of patients with chronic candidiasis. Mucocutaneous candidiasis and candidiasis endocrinopathy syndromes, these are usually associated with secondary candidiasis, meaning that candidiasis is associated or it comes after a primary immunological disorder. Now, lab diagnosis of candidiasis includes clinical examination of signs and symptoms. Second is cytology, exfoliative cytology, and the use of special stains. And the third is the use of biopsy. Fourth one is with culture. So exfoliative cytology is when a smear is prepared from the surface of the mucosa, including the candidal pseudomembrane. This is stained with one of these stains. It can be with pyridic acid Schiff, potassium hydroxide, methenamine silver, or crystal violet. And with this picture shows a section stained with PAS where the hyphae are seen as bright magenta stained hyphae. So PAS is when a cytological smear is from the pseudomembrane is stained with PAS, the Schiff's reagent will show up the fungal hyphae as a bright magenta color. Additionally, here we can also see the budding blastospores and the pseudohyphal forms. Potassium hydroxide is very efficient for a quick and rapid diagnosis because this will lyse the background of epithelial cells and allow the yeast cells and the hyphae to be seen. So this is useful for rapid evaluation. The only limitation or disadvantage is that this cannot be kept as a permanent record and it cannot be mounted. The third method of diagnosis is by biopsy and histopathological examination. And most cases will show that the fungal hyphae penetrate only the superficial layer of the keratin, and small collections of neutrophils, which are called as neutrophilic microabscesses, can also be seen in the spinous layer of the epithelium. So here in the picture, we can see that the pink hyphae of Candida albicans are seen tangentially penetrating the superficial parakeratin layer of epithelium. This is stained with PAS. Culture is the final confirmatory diagnostic method for the fungal infections, and the preferred media for culture of fungal organisms is dextrose, Sabarad's agar media. Additionally, cornmeal agar or blood agar can also be used, and the fungal hyphae are seen as cottony white colonies seen on the growth media. Treatment of Candida infections. For mild infections, nystatin can be used, and clinically what is commonly used is clotrimazole or candid mouth paint, and clotrimazole troches. Clotrimazole troches can be dissolved within the oral cavity and swished and spat out. So nystatin and clotrimazole are the two commonly used medications for topical or mild and local infection. Systemic treatment may be required for more severe infections. The systemic treatment can include ketoconazole, fluconazole, itraconazole, as well as amphotericin B, which is usually reserved as an IV drug for very severe Candida infection. Now, most fungal infections caused by Candida will resolve quickly after a course of antifungal agents and when the predisposing factors are removed. But in case of HIV infection, Candidiasis is an indicator disease, which shows that the disease is progressing or that the disease is present. Now, it is the most common intraoral manifestation of HIV infection, and so it is also called as an indicator disease for HIV. Among the four patterns which are seen, pseudomembranous and erythematous types are very common in HIV patients. Here, the treatment is more difficult, more refractory to treatment because of varying counts of CD4 cells in the HIV patient. Now, that concludes the class, the topic of Candidiasis. Thank you.